Central venous catheter. Learning outcomes to describe the sites of central venous catheterization, understand why central venous pressure monitoring is performed, demonstrate how to perform central venous pressure monitoring using a manometer and a transducer, state normal parameters for CVB. Introduction. The central venous pressure reflects the right atrial pressure and it is similar for measuring jugular venous pressure. The central venous pressure measurement is often associated with intensive and critical care settings. Circulating blood flow into right atrium via inferior and superior vena cava. The pressure in right atrium is known as central venous pressure. Critically ill unstable patient may need hourly measurement of CVB. Types of central line: single, double, triple, quadruple, and quintuplate lumen. Indication for central venous line insertion: need for IV access and failure of peripheral access. Peripheral access too painful or very difficult. Long-term IV access anticipated. Infusion of drugs which may cause peripheral problems, such as vasoconstriction and phlebitis. Hemodynamic monitoring. Volume resuscitation with large poor central lines. CVB measurement, right atrial pressure, to obtain frequent blood samples to determine how much fluid is needed in 24 hours. Insertion of pacing wire. Relative contraindications: bleeding disorder, platelet count less than 50,000. Bleeding is uncommon and easily managed. Anticoagulation or thrombolytic therapy. Distorted local anatomy, cellulitis, burns, severe dermatitis at site, vasculitis. Sites for insertion of CVL: internal jugular subclavian femoral vein, brachial vein for long lines. Factors affecting the CVB: systemic vasodilatation and hypovolemia, which leads to the reduced venous return into vena cava and reduced right atrial pressure. Right ventricular dysfunction and pulmonary hypertension leads to high right atrial pressure, as does tricuspid and pulmonary stenosis. Advantages versus disadvantages of sites for insertion of CVL. Femoral advantages: ease of insertion, especially in unstable patient, low incidence of insertion complications. Disadvantages: patient discomfort, limited patient mobility, short functional life. Subclavian advantages: patient comfort, extended functional life. Disadvantages: technical expert required for insertion, risk for serious insertion and delayed complications. Internal jugular: extended functional life, decreased risk for serious complications. Disadvantages: technical expert required for insertion, patient discomfort, catheter difficult to secure. Cephalic and basilic vein: patient comfort, ease insertion, minimal incidence of insertion complication. Disadvantages: selected patients with good peripheral vessels, inadequate blood flow rates. Normal CVB measurement: the normal CVB is between 5 to 10 centimeters or 2 to 5 millimercury. It increases 3 to 5 centimeters when patient is being ventilated. CVB increases in the following condition: overhydration, right-sided heart failure, cardiac tamponade, constrictive pericarditis, pulmonary hypertension, tricuspid stenosis, and regurg. Stroke volume is high. Clinical interpretation of CVB: high readings. Other features may be present, such as unilateral breath sounds, asymmetrical chest movement, resonant chest with tracheal deviation, rapid pulse. Diagnosis to consider: tension pneumothorax, treatment thoracentesis, then intercostal drain. High breathless third heart sound, bronchiflosis, sputum, edema, tender liver, deep tempshioctama, heart failure. Treatment with oxygen, diuretics. Setup: consider inotropes. Very high, rapid pulse, muffled heart sounds. Diagnosis to consider: pericardial tamponade. Treatment: pericardiocentesis and drainage. Low CVB readings in hypovolemia, decreased venous return, excessive veno-oral vasodilatation, shock. If the measure is less than 5 centimeter water, it means that the circulating volume is decreased. CVB reading low. Other features may be present: rapid pulse, blood pressure normal or low, low urine output, poor capillary refill in hypovolemia. Treatment: give fluid challenge until CVB rises and doesn't fall back again. If CVB rises and stays up but the urine output or blood pressure doesn't improve, consider inotropes. Low or normal or high, features to present rapid pulse signs of infection, pyrexia, vasodilatation, or vasoconstriction. So it is sepsis. Ensure adequate circulating volume as above, and consider inotropes or vasoconstrictors. Normal readings: rapid pulse, low urine output, poor capillary fill. In hypovolemia, treat as above. Vasoconstriction may cause CVB to be normal. Give fluid challenge and observe effect as above. Unreliable CVB readings: problem may be pulmonary emboli or high intrathoracic pressure. Effect in CVB: high pulmonary vascular resistance, left side pressure and function may be normal. A higher than normal CVB may be needed to ensure adequate return of blood to left side of heart. Left heart failure resulting rise in pulmonary venous pressure and right side heart strain. Initially CVB may be normal, but it is increased with significant failure. Constrictive pericardial disease: paradoxical rise in CVB in inspiration and fall on expiration, opposite of normal in spontaneous breathing patient. The absolute level will be higher due to embedded filling of the heart. Central venous line insertion. Equipment: patient position, procedure after insertion. Equipment to be sterile with sterile gloves and xylocaine and gown, catheter special size, water manometer, flush solution with complete CVB line, dressing set. Patient position: patient to be on the side of the bed and the bed is high enough so the physician wouldn't have to stop over. Patient should be flat without a pillow. Trendelenburg position لو العيان hypovolemic. The head is turned away from the site of procedure. Rest strains if necessary. Procedure: skin preparation. Prepare before sterile gloves and allow time for sterilizing agent to dry. Drape large enough and handle sterile by assistant. Hole in the area of placement. Prepare the tray. Prepare the equipment before starting. Anesthesia with local anesthesia with xylocaine. A nursing rule: after CVL insertion to flush lumens and obtain chest x-ray, monitor sites for bleedings, assess breath sounds and assess circulation and assess for hematoma, and dressing and flushing. Using the central line, flush every before and after shift with normal saline. أحيانا بنستعمل heparin. Close ports with clamps if it is not in use. It can be used for blood drawing عن طريق ان احنا نسحب 10 سنتي وبعد كده نسحب عينة for samples. Central venous line placement. Complication can be immediate or distant. Immediate complication زي الهيموثوركس. Pneumothorax is the most common. Bleeding: it is more with patient with coagulopathy, easily to control زي في الفيمورال CVB. Arterial puncture, visual erosion زي large vessel perforation. Nerve injury, arrhythmia, catheter misplacement, emboli, cardiac tamponade. Delayed complication: arrhythmia, infection. It is a late complication بيحصل أكتر في الفيمورال أكتر من internal jugular وأكتر من subclavian. Catheter misplacement, vessel erosion, emboli, cardiac tamponade, thrombosis. ازاي نقدر نقيس السي في بي؟ عندنا طريقتين: يا اما المانومتر سيستم اللي allow intermittent reading and it is less accurate than transducer system، او transducer system allow continuous reading on a monitor. CVB system بيتكون من bag of saline, reservoir, 3-way tape connected to manometer, reservoir and patient CVB by tubing. System is primed with fluid before starting. The patient بيبقى supine if possible. Manometer has spirit level at 0 point is aligned with right atrium عن طريق using اللاند مارك بتاعتنا الميد axillary line عند الفورس intercostal space. الميجرمنت بتاعتنا لازم تتعامل على constant level. Phlebistostatic axis اللي هو الفورس intercostal space في الميد axillary line. CVB measurement: line up the manometer arm with the phlebistostatic axis ensuring the pupil is between the two lines of spirit level. Move the manometer scale up and down to allow the pupil to be aligned with 0 on the scale. This is referred as to zeroing the manometer. Turn the 3-way tape off to the patient and open to the manometer. Open the IV fluid bag and slowly fill the manometer to level higher than expected CVB. Turn off the flow from the fluid bag and open the 3-way tape from the manometer to the patient. The fluid level inside the manometer should fall until gravity equals the pressure in central veins. Turn the tab off to the manometer. When the fluid stops falling, the CVP measurement can be read. If the fluid moves with the patient breathing, read the measurement from the lower number. Turn the tape off to the manometer. Document the measurement and report any changes or abnormality. By using a transducer, explain the procedure to the patient to gain informed consent. The CVC will be attached to intravenous fluid within pressure bag. Ensure the pressure bag is inflated up to 300 mmHg. Place the patient flat in supine position if possible. Alternative measurement can be taken with the patient in semi-recumbent position. The position should remain the same for each measurement taken to ensure accurate comparable results. عادة بنقيس من خلال الوايت أو البروكسيمال ليومن. Tape the transducer to phlebostatic axis or as near to the right atrium as possible. Turn the tape off to the patient and open to the air by removing the cap from the three-way port, opening the system to the atmosphere. Document the measurement and report any changes or abnormalities. Press the 0 button on the monitor and wait while the calibration occurs. When 0 is displayed on the monitor, replace the cap on the three-way tape and turn the tape to the patient. Observe the CVP trace on the monitor waveform. Modulate as the right atrium contract and relax, emptying and filling with blood. ده شكل CVP waveforms. الwaves عندها 3 peaks A, C and V and 2 descents X and Y. A is the rise in right atrial pressure caused by atrial systole. C, it is the ventricular contraction causes the tricuspid valve to bulge upward into right atrium. X, it is a decrease in pressure in right atrium as the tricuspid valve move away from right atrium during ejection of blood from the right ventricle. V, it is the peak in atrial pressure during ventricular systole when the tricuspid valve is closed. Y, it is the tricuspid valve open and blood rapidly empty into right ventricle during diastole. ده الويف CVP waveforms with ECG waves. Removal of central line. It is aseptic procedure. The patient should be supine and held tilted down. Ensure no drugs are attached and running via the central line. Remove dressing. Cut the stitches. If there is resistance, then call for assistance. Apply digital pressure على مكان السنترال لاين عشان لو في أي bleeding أو هيماتوما. وبعدين بنحط دريسنج. ميرسي جدا، شكرا.